Meeting to order. The Kern Valley Healthcare District Board of Directors, and today is April 11th. Welcome, everybody.
Welcome.
So first order of business is approval of our agenda. Do we have any, I do have a couple changes, but they relate to the consent agenda, so I'll wait on those. Are there any other changes to the agenda that anybody would like to see?
The consent agenda is not what we change right now, right?
That's right.
Okay, then I'll make a motion, we approve it, or do we need to approve it?
Yeah, we need to.
Okay, make a
So,
motion, we
We'll
approve
have
it.
Gene's motion. Do we have a second?
I'll second Ross.
Thanks, Fred. Gene, your vote?
Yes,
Fred?
Yes.
Catherine?
Yes.
John?
Yes.
And I'm a yes. So we need to do a flag salute and then an invocation. Let's see if we have Mark on today. There's Mark. Mark, could you lead us in our invocation and Tim in our flag salute?
Sure.
Thank you.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Heavenly Father, as we come before you today in this meeting of the Board of Directors to hear and make decisions about the direction of the Kern Valley Healthcare District, we ask that you guide us and you bless those decisions with good outcomes so that we can better serve this community. In Jesus' name, amen.
Thank you both. Our mission statement is here on the agenda for those of you who are interested can read through it. Item C on our agenda is reserved for public comments. And we invite the public to address this board on matters that are under our jurisdiction, but not on today's agenda. Are there any members of the public wishing to be heard? Okay, seeing none, then we will move to the consent agenda. The consent agenda are routine and non-controversial items that staff and committees have put on consent agenda that will be approved with one vote unless any member of the public or any member of the board wishes an item to be removed and discussed individually. So Gene, I know that you had wanted something pulled from the consent agenda.
yes, the beta at the Finance Committee, we agreed to get the last 3 years' experience, and so we could compare it how it's going, the trend, and
So we don't need to discuss it at this moment. We'll just
yeah, we need to table it. Now, the Alliance, the other part, the property and casualty part of it, it's okay to go through, or the Alliance insurance is fine. It's just the beta liability and officers and directors that I'm
Did you
interested in
get-
looking at the trends.
Did you
Okay.
get the 3-year report that I sent out last
All I
week?
saw was 1 year from 21 to 22.
No, there was 22, 21, and 20. As a matter of fact, I said it a second time because I think I mislabeled the first time. It was 2020 and 2021.
Okay, if we could pause for just a sec, guys. If we could pause for just a second, rather than have the discussion right this moment, we will pull item G and pull item I. I'm sorry. Item G and item I from the consent agenda. And we'll discuss that under new business, or rather old business, because these are renewals. Also, from the consent agenda, I have some changes to some minutes. So I'd like to remove the Board of Directors, the March 7th Board of Directors minutes, which is Item 1 on the consent agenda. The Building and Planning Committee meeting minutes of March 29th. So that's item 3. And then the March 30th Finance Committee meeting minutes. So that's item 4. So we're removing item 1, 3, 4, and then items 6G and 6I. Are there any other removals from the consent agenda? Okay, so we will,
And we'll be discussing those, right, Ross?
yes, we'll be discussing those. I was just trying to find a good place to do that. Let's just have the discussion on these items right before the reports. So we'll just move them to the bottom of the consent agenda on the agenda. And so
Ross,
all,
might I make a suggestion?
yeah,
If you're going to be taking action on them,
uh-huh,
let's move them as a business item.
okay,
If they were just discussion, we could do it by reports there, but since it's going to be, if they're going to be, you're going to be approving stuff, let's do it under G. New business.
okay,
Just
all right,
as
Scott,
4, 5, 6, and 7.
okay. Okay, thank you, Scott. Thanks for your
Yeah.
guidance. Okay, do we have a motion on the revised consent agenda?
Make a motion, we approve it as revised.
I'll gladly second, Ross.
Thanks, Fred. Any discussion?
No, sir.
Any members of the public wish to be heard on the consent agenda? Okay, then Jean, your vote.
Yes,
Fred,
Yes.
Catherine,
Yes,
John,
Yes.
and I'm a yes. So our consent agenda is approved with those items removed. Which brings us to item E, reports. And first up is the foundation report.
good afternoon. I just want to remind everybody that Houchin blood draw is tomorrow, April 12th. It starts at 9 o'clock. Last time I talked to them, they were full. So we're doing really good on that and they're really enjoying coming here to the hospital. I want to let everybody know our auxiliary luncheon is going to be on the 13th. Some of the board members will be attending. That starts at noon. That'll be in Sierra Vista. Take back medication is happening on April 22nd at the pharmacy. That's at 10 till noon. And hospital week is coming up May 8th. And so you'll hear more about that as the weeks come forward. Any questions? That's my report.
Thank you, Debbie. Okay, item 2, auxiliary report.
Thank you. Good afternoon, everyone. Don't really have a lot to report. The thrift store is we're having awesome days. We had a bake sale the last 2 weeks and we now have summer out. We sold out on life jackets within the first 5 hours today.
Wow.
Yeah, so we're having some killer days down there. That's all I have.
Thank you, Cindy. Any questions or comments for Cindy?
I was gonna ask her if she's hiring people to park their cars there or something, because every time I drive by, there's a bunch of cars out there. Great job.
Thank you.
Thank you.
And I need to get back to work now because I'm running shorthanded today. So have a great day.
Thank you for
Right.
being here.
Hey, Ross, just a quick question. Did we actually vote on the other consent agenda items yet?
Yes.
Okay,
I couldn't remember.
all right, I couldn't either. That's what I was asking Mark. You couldn't either. Thank you.
We did, right?
Yes.
We're kind of like, huh?
I thought so. Maybe we need to run the recording back. Okay. Item 3, medical staff report. Dr. Finstead.
Thank you, Ross. The Pharmacy and Therapeutics Committee met on March 9th. We discussed COVID-19 preparations. And I guess the bottom line on that is we certainly seem to be in a pretty sweet spot right now with numbers way down. Everybody keep your fingers crossed. We discussed the plan of corrections for the recent survey. We reviewed and added 3 new reports to the Pharmacy and Therapeutics Committee related to pharmacy. One is the Pharmacy Biological Sampling Report, the QA report for compounding analysis, and temperature alerts for medication storage incidents. We reviewed 8 and approved 4 policies. The approved ones were sterile compounding and environmental testing. Also for the same type of thing in the pharmacy work area, sterile compounding trainer qualifications, and then medication consultation. We also reviewed a report from the Antibiotic Stewardship Committee, and that report will also become a regular part of the P&T agenda. In addition to that, we reviewed our regular reports, including blood usage, blood culture analysis, CAPS report, and medication error reduction program. We also reviewed the pharmacy biological sampling and temperature alert incidents. We also reviewed the reports on procedural sedation. Most of these are done in the emergency room. Then on March 22nd, we had the Medical Executive Committee. We approved the above mentioned policies. We reviewed one that we're still working on that's related to intravenous contrast administration for X-ray CT procedures. We reviewed the above mentioned COVID-19 issues, reviewed the recent plan of corrections, and then reviewed our regular reports, including medication shortages, delinquency rate, and medical staff plan of correction items. Then finally, on March 24th, the Emergency Department Committee met. They discussed performance improvement goals for 2020, including plans for a sepsis program. The review made some changes to intravenous pump settings related to administration of oxytocin. Reviewed a recent Code Blue, and we'll be adding Code Blue critique to their regular agenda. Also reviewed the emergent medications list. This is the list that we have submitted to the Board of Pharmacy that are considered to be emergent medications that need to be compounded here in our pharmacy things. So that's a very specific list. If we have additions to that, we need to let the Board of Pharmacy know about that right away. The list is a comprehensive attempt, but the attempt part is pretty operative, as we cannot conceive of all emergencies. We had added actually medication recently related to a newborn in the ED that needed medication that we hadn't considered. In addition to that, the ED committee reviewed their regular reports regarding quality measures, medication error reduction program reports, blood culture analysis, and procedural sedation. And unless there's any questions or comments, that's the end of my report.
Any questions or comments, board? I do have one, Dr. Finstead.
Sure.
On one of the last topics you were talking about, the compounding in the ER. Is there a procedure in place? So if you discover a medication that we need that's not on the approved list, that there's some immediate way to follow up with a pharmacy board in the next day or two, so that it doesn't look like we're just ignoring it?
Right, so that's the plan. So if it comes up that we need to compound a medication for an emergent situation, and that is based on the ED physician's judgment, then we're to notify the pharmacy right away. And Tim can probably spell that out a little bit more as far as the actual details of that notification.
Yeah, we've committed to at least 24 to 48 hours, 24 hours if it's during the week, 48 on the weekend, to let them know that we had to add it for an emergency reason. And so that's been communicated to the pharmacists and everyone in terms of what we need to do. Our biggest concern obviously was to make sure that the patient got taken care of and the care was provided that needed to be. And we'll worry about the other one afterward, but again, within a very timely period.
It doesn't really seem to me like that's the issue. It's us compounding medications and not letting them know that gets them going.
Yep.
Okay. All right. Well, I'm glad you guys are on top of it. That ended up being a sore spot with our surveyors. So good call.
Hey, Ross?
Yeah.
I have a question on that. I'm assuming this is all being done electronically, but are we getting written response acknowledging that we've attempted to notify agent
No,
A, B, and C?
it's not an approval process. And this thing goes to probably about 4 or 5 different people at Department of Public Health and also the Pharmacy Board. So it's shotgun. It's an alert to let them know that we've modified our list. That's all. It's not a permission that we have to get to do that.
I understand, but I mean, are they at least acknowledging that we've notified them?
No, they have not.
Interesting. Okay.
Yeah.
Okay. Thanks, Dr. Finstead.
Our big issue, like I said, Fred, just in response to that, is just to make sure we've got proof that we've done it. And so again, if there's any question about it, we have the ability to document the fact that we did in fact notify them timely. So that's really what my concern is.
I understand. It would just be nice if somebody was acknowledging us so we knew what was happening as well. I would just for our records.
We would agree with you.
Okay. Well, that brings us to the fourth report, which is the Chief Executive Officer, Mr. McGlue.
Okay, again, just kind of following up on that, we did submit our response to this last plan of correction that came out. It was submitted to CDPH on Thursday. Was a full team effort. I want to personally thank Mark and Heidi, our pharmacy staff, laboratory, medical staff, office, and so forth, infection control, Mary. Everybody participated in this. And, again, it was, and we had everybody read through the final report to make sure that everybody understood what was being committed to and what was in there. So there's no surprises or anything say, well, I didn't know that we were supposed to do that. And I think that's kind of what happened last time, is some things didn't get through the communication process and so forth. And so we wanted to make sure that everybody had signed off on that. And then, one of the things we are continuing to do while we're waiting for that response is Mark and I are going to working on putting together a survey binder to basically put together copies of evidence of everything that we've done that we said we're going to do, so that if they show up, it's basically, here's the binder. You can look through, you can see the documentation of what's been done without having to sit there and wait for people to go scramble to try to find things. It just is so much more smooth and a clear process. So we're working on that. And so, like I said, we're going to continue. We don't know how long it's going to take them to get back to us, but hopefully soon.
Tim?
Yes.
On that topic, before you move on,
Yeah.
Whose job is it now to review that list on a weekly basis or periodic basis to make sure that things are getting done?
It's all of ours. I'm taking the responsibility as well, and like I said, I put together a crosswalk on all of the items that were in there that shows what's supposed to flow through to what committees and so forth. I'm also sitting down with Marie going through the agendas for the upcoming medical staff meetings to make sure that the items that need to be discussed are on that agenda to make sure that we get evidence and credit for the fact that they were supposed to be done. So we've got a whole list of things that we're doing to make sure that we get through. We just can't take any chances that we're going to miss something. That's all.
Exactly. Thank you.
You're welcome.
Can I ask something, or I just want to make a statement?
Yeah.
One of the things that usually comes back to bite us is when we don't do what we're supposed to do, bottom line, and then we add everything to make the correction, and then we've made it harder for us and more time consuming for us to make sure what we should have done with the first step. You know what I mean? We
Oh, yeah.
create more work for us.
Oh,
So
no.
it's a healthcare issue. We always create more work instead of just, if it's not done and documented the first time, it wasn't done.
Right.
So I've seen it's hard. We create more work for
Oh, yeah.
ourselves.
Like I said, we've learned a lot of that from the SNF. Obviously, the SNF gets surveyed more than any
Right.
place. And, we've got that pretty much down to a science over there in terms of making sure that
Until
we track
they
it.
ask somebody something
Yeah.
that's in that book and somebody doesn't know.
Yeah.
That's where we fall
And
short.
that book is going to be a live resource that we keep adding things to. As we do things, we'll get that updated, and that'll probably fall on me or one of the other
And then
persons to maintain it.
And then are there gonna be like continuous, short, let's meet at the nurse's station and we're gonna cover this real quick? So, you know what I'm saying? Just to make sure everyone knows, because the state always asks somebody that's
Yeah.
not in the loop.
Absolutely. Oh, yeah.
I mean, they just can find them.
Got like a little sign on their forehead.
Yeah.
Ask me. That's right. No, it's true. It's very true. Like I said, it's communications has to be system-wide on this stuff,
Yeah.
especially for something that's this critical and so forth. And so, yeah, those steps are in place. Mark has created certain tools that we're putting on the computer screens for the staff, like the antibiograms and so forth, and other information that's coming through the antibiotic stewardship committee to make sure that people have seen it. They can see it anytime they want. They can just pull it up and look at it, or any other articles or things like that, research that we're doing or protocols that we're working on. They'll all be there and so forth, so that nobody has a question about it. It's easy to find. Mark's educating them in his staff meetings and so forth. So yeah, I mean, that's the way it's gonna have to be from here out on everything, not just getting past this. It's just the way it's gotta be. So
Well, thank you.
you're welcome. We did receive our second half of our dividend from Beta, which was sent out to us on April 1st. It was for $86,000. Again, we received one, I think, back in October. We got the other half of that, which was a total of about $172,000 total that we got in refund from them. Pleased to report our battery system is working. We had 3 tests this last week where our power went out here in the valley. It takes about a second or a second and a half to switch on and so forth, which is still enough to trip some of the computers in-house. But again, it did provide power throughout the hospital, which was great. Especially one, because we heard, like I said, it was out for like 10, 20 minutes and stuff like that. And we didn't know. So you would not have even noticed it. So that's working well. I think I reported this in some of the other committees before. We did receive a QIP program payment of $362,000 from Kern Health Systems. Also a HRSA grant approval was for $258,000. A lot of that was COVID related. I don't know, Barb, if we got to check the first half part of that, it was $218,000 or something was supposed to come through.
I think we did.
We did, okay.
The QIP.
Yeah, and then the
Yeah.
last part will come, I think, at the end of the year. And then our new HVAC system with HEPA filtration is currently being installed. The air conditioning unit is almost as big as the pharmacy itself. So it's incredible how they over-design this stuff. The website, as I reported out to you all before, went down. We had a problem with the old system. Apparently there was a license renewal that was buried in the programming somewhere that failed. And since none of us knew how to program that system, there was no way to go back and get the license renewed. So we made a decision between Carrie and I to go ahead and move the new system up, because a lot of it they'd been working on it pretty steadily, and had it probably about 75 to 80% of the way there already. They've been making modifications literally daily, I think, as we've gone along, just getting that thing back up to speed. And it's a whole lot easier to manipulate and so forth. We've gotten some good feedback on it. And they're very responsive. We turned something in this morning. We might have it back and reprogrammed by this afternoon or tomorrow at the latest. So it's been great. And so again, we're getting the pictures worked out. I think there was a little mix up there for a while. It had some of us listed as board members. And then I think we still didn't have Catherine's picture. I think we've got.
And it's a good one.
We've got
Just
that.
putting that out there for you.
It's not that worked
They
out.
have it.
And so we're getting those little things worked out. So Vince Fong will be here on Thursday afternoon, 3 p.m. to meet with us. He will be our new representative going forward. We will not have Mathis anymore. And so, I appreciate everything that somebody Mathis did for us, but like I said, I've been working very closely with Vince for the last 2 years during COVID, as we've had these weekly CEO meetings with all the hospitals here in Kern County. Vince has been the one constant that's on every one of those calls, the only legislator that was on those calls. Wanted to make sure that we had what we need. If there was something that we didn't have here in Kern County, he would go to the state and he would find a way to get it for us. So he's been extremely responsive. So I'm very happy to hear that he's going to be our representative. So he's going to come up and kind of see the site and kind of get to know us a little bit and see what our needs are. And we'll go from there. And so, and as I said, I was going to mention the auxiliary luncheon and also our take back medication program, but someone beat me to that. So she left. So, but anyway, that's my report.
Thanks, Tim. Questions or comments from the board? Okay, thank you.
Sure.
All right, our Chief Nursing Officer report, Mr. Gordon.
Yeah, good afternoon. A few things that I have to mention. One of them is that we currently have concerns with some health plans that are basically neglecting their responsibility for providing their members with the level of care necessary. We have admitted their patients for a medical condition, and once the medical problem has been managed, we discover an underlying health need for which we do not provide services. Most of the time, it is a behavioral health need, such as aggressive dementia care or memory impairment. Our facility does not have the ability to care for some of these patients with these higher levels of care. And this causes the patient to suffer from a lack of effective care and treatment, and it puts our staff at risk for injury and stressors of their own. I needed to get that out there for everyone to hear that.
I'd like to make a comment on that too. Just,
Okay.
Again, this is one of the ones we've been having trouble with recently is call care. This is, we've gone all the way up through the top of the medical director for call care, who basically just says, throw their hands up there and says, well, that's your problem. It's not ours. This is supposed to be managed care, and they're supposed to help us manage that care and make sure that we get patients. We asked them for a list of other facilities that we might be able to transfer a patient of theirs to. Gee, can't give that to you. We don't know. And so, we were on the phone Friday evening trying to get a hold of, I contacted the CEO down at Kern Medical to see if we couldn't get that patient into their facility. And we left her, everything looked like it was great. And then I get a phone call later that evening, or voicemail message indicates says, well, that didn't quite work out. They really need a neuro consult. And we're sending them to Heart Hospital, but Heart doesn't have the ability to care for a patient with this patient's particular issues. And so it's just frustrating. This is, as Mark said, a very combative situation, and they've had several employees injured by this person.
We've had five injuries with nursing staff. 2 of them are still out on workers' comp. Yes.
Yeah.
Yeah.
So it's just, and it gets very difficult when they just throw their hands up and say, we're not going to help you. It's your problem. You deal with it. You go find someplace. You know, there's no family, there's no nothing. Yes, sir.
Is there any specific guidelines? Is there a degree of dementia or Alzheimer's or whatever it is? I mean, if we're in the right, they're gonna have to do or take what we can't handle.
They're
I mean, it's
supposed
gotta
to.
be- If it's specific, now if it's borderline or gray areas, I mean,
Well, that's why we try to get them into current medical, you know, primarily for the psych issues and so forth. And
I'm considering filing an SOC 341 for neglect against the insurance carrier.
right.
okay,
It's
so
coming.
then you do have specific guidelines of what we're not able to do.
Oh,
and what
absolutely.
They're not doing.
Yeah, no, this is clearly, she doesn't really have a medical need to be here. And so forth. And this is the problem. We get in here, they dump them on us and then they refuse to move them. And then we're stuck with them. And like I said, we've been told by Qual Care says, well, that's sorry, we're not paying for you. As of about 4 or 5 days ago, they said, well, we're not paying anymore. And you're done. So they don't have an acute need, so therefore we're not paying. And so we're sitting there, well, tell us how to get them to the right level of care. Tell us who you've got contracts with so we can transfer this patient to get them to the right level of care. And they don't.
Not to mention it's an unsafe discharge if we send them home.
You can't.
Can't do that.
Yeah.
can't
Scott should be chiming in on this.
Yeah, we're gonna need Scott in this, I'm sure.
How can
before
they do
it's all
that,
said and done.
Scott?
You guys, I have a question.
Yeah.
Maybe I'm off base here. But if you've got a patient that's basically assaulting our employees, doesn't it become a much more legal issue from?
Sure.
We called the sheriff
called the
and
sheriff,
he said he can't do anything because that patient doesn't have the mental capacity to be responsible. So they left him out.
And why wouldn't they take into a psych ward after the assault?
Scott's not responding. Scott, can you hear?
Yeah, this is the first I've heard about this. I'll talk with Tim offline. I don't want to talk about it in a public.
Yeah,
meeting.
Will you report
we need,
back? I
obviously,
mean,
we
it's
need to get more
serious,
specifics for
right?
them, but the issue is this just give you just a kind of a sample of some of the things that we have to deal with, and it's beginning to increase in frequency. It was a big issue during COVID when everybody's beds were filled, and you know, now we're in a situation where that's not the case, but we're still having these issues come up.
They're
Sorry.
back.
That was Carrie's fault. It's okay.
That explains a lot.
All right, so if you don't mind, I'll just move on with my report. I appreciate the discussion.
Thank you.
So
It's education.
COVID numbers in the ED are steadily trending downward. In the last 5 or 6 weeks, we've had less than 1%, around 0.5% positivity rate. The transportation service is currently providing 4 or 5 rides per day with various appointments. We have a second driver per diem for when the load is heavy and appointments get too close together sometimes, and I can't have one person picking up 2 people at the same time. So the kiosks have been in service for the hospital employees, and we're looking at reconciling daily reports to make sure that, you know, the staff are checking in. And frankly, I know that they are checking in because I'm getting text messages pretty regularly about people answering the questions and alerting me to their problems. So, and then the last thing I want to talk about is antibiotic stewardship training. This continues with the implementation of the antibiotic stewardship core elements at small and critical access hospitals. One of the prime reasons for this is trying to improve antibiotic use in the hospitals. It's imperative to improving patient outcomes. Antibiotic use has they have well-known unintended consequences like C. difficile and you know, the superbug use or incidents. So what we need from the hospital, basically leadership commitment. That's the first core element is leadership commitment. Number 2 is accountability. Number 3 is the expertise from the pharmacists as far as which drugs are appropriate for which bugs are out there in the community, whether they be pneumonia in the chest or urinary tract infections or other kinds of things. So that's what we look at when we look at antibiotic stewardship. And then action, tracking, reporting, and education. Those are all parts of those core elements that we're looking at in the antibiotic stewardship program. You'll find a letter of commitment in the
There you go. Thank you.
packet today, I think. Have any questions about that? I certainly am willing to answer those. And if there are no questions, that's the end of my report.
I have a question.
Absolutely.
How long before we're gonna have to charge for that transportation on the,
That is a good question. August
thank
is August is the August is the time when that runs out.
okay,
And so I still have, I'm not sure if Barbara has successfully gotten the billing structure set up for that, but
We pretty much have to start over. We don't have the same driver.
oh, that's right. We had to replace Dave Chapdelaine because he went out on over the road again. So we'll have to start over on the application process for getting current health systems reimbursement. We may have to start charging in August.
Is it driver specific or shouldn't matter for?
They have to be registered. They have to have all the certifications and it has to be on record.
Gotcha.
Or could we change it to like a donation system to where we could actually get a little heavier volume and people could pay what they felt like was reasonable?
I don't think we can handle the volume we have now. We're doing
Oh, okay.
5, 6, 7 rides a day. And actually, one of the drivers is per diem, but he also drives for the rafting company. So in the middle
oh,
of,
that's picking up.
in the next few weeks or months, he's going to be busy driving those. So I may have to resort to having another driver per diem.
There's no snow.
If you got it mixed up, some of the patients might like it. They could end up on a rafting trip.
Well, there's a lot of people that may abuse the system as well. Because a free ride with gas prices being $6 a gallon, people are gonna call just to get a ride instead of. So I see the writing on the wall for abuse in a system like this as well. So
I work at a clinic. I could just have them pick me up and,
take you to work.
yeah.
They wouldn't- oh, that's
And then
good.
pick me back up after.
Thanks for learning.
So, yeah, no, we're looking at those things, and Gene, I have been thinking about that. Probably be $20 a pop to go for a ride, so.
Yeah, we just have to adapt. Once we get there in a couple months, we'll just have to try whatever we can.
Yes, sir. I don't want the drivers to carry cash, though, I don't think.
Well, people wouldn't donate too much around here, so we wouldn't have to worry about it.
Yeah.
You're probably.
All right,
Hey,
but
Mark,
that's my
what's-
report. Sir.
Mark, what's the primary destination? Where are they bringing the patients
They're
to?
bringing, mainly it's physical therapy right now. That's the big draw, that and the rural health clinic. There are some pharmacy deliveries and things. We're not delivering medications, but we're taking patients to and from the pharmacy.
Okay,
So they can get, so those are the things that we're actually doing, yeah.
great.
I do have our new rehab director here, Pete Scogdemio, who's sitting behind off camera here. So welcome to our first board
Been
meeting.
excellent bringing people in.
Yeah.
Very on time, very professional.
Yeah.
Good to hear.
I had a question too on that qual care issue. So who's qual care?
Gene, you want to answer that?
Yeah, it's a group of doctors that get together and get money from Medicare or to take care of them, just like Kaiser, you're familiar with Kaiser, it's basically the same concept. And so the less money they spend, the more they make.
Okay,
So they want to conserve the best they can, but as a rule, qual care is good to work with, as a rule. So they're one of the better ones. BFMC is one that wants to conserve the most as a rule, but they vary. But you're familiar with Kaiser, right? So.
Yeah.
Okay, is that explaining enough?
thank you.
Okay.
Like capitation contract, basically.
So
Well,
the
What they do, John, they take the average that that a 61-year or 65-year-old would cost. And they give that to the group. Or if it's a 90-year-old, they average for a 90-year-old. And that group has all that money. If they don't see anybody, they keep all the money. And so they want to conserve, but at the same time, they want to do preventative, so they keep them healthy. So it's a good system. It works good, but
Usually, yeah.
yeah, as a rule, in this case, it's not working.
So Mark, you had mentioned earlier you were this close to filing a complaint. I don't know who the complaint gets filed with. Why are you hesitating at all?
That's a good question too.
Why haven't we moved forward with that? I mean, where's
I
the
think-
accountability?
Before we want to do that, I want to reach out to the administrative director for QualCare. We've talked to the medical side. We've gone up as far as we can on that side. And I want to get the administrative person in charge on the phone and see what we can work out through them. And if that doesn't work, then we've got no choice but to report it up through the state. So I believe that goes to the Department of Managed Care.
I think, Ross, the reason I haven't and I'm hesitant is because the patient is safe at this time. That's about the best I can answer that.
So I'm facing making some Medicare choices because I have a birthday coming up, and in my big book that I got, from with all the providers, and it says QualCare, their affiliated hospitals are Memorial and Mercy. So can we just effect a transfer to Memorial or Mercy for this patient?
Not without their approval.
Yeah.
They have to bless that. This is a topic for another day. But yeah, it's a very complicated process.
Okay. So are you going to be talking to the administrator today?
We will do what we can. Yes, absolutely. As soon as this meeting's over.
Who is the administrator?
That's what we got to find out. They
You don't know him?
It's not really broadcast. No, I don't. It's one of the few people I don't know.
Okay. All right.
I know Kaiser and I know the others, but I don't know that one.
Okay. All right. Well, keep us informed.
You bet.
Did you have other things, Tim? I'm sorry, Mark.
No, that was it. That's the end of my report.
Okay.
Well, I got lots of other things if you got a minute.
We'll move on. We'll move on to our Chief Financial Officer report, Mr. Recupero.
We can't hear you, Dave. You're on mute.
Okay, yeah,
There
can
you go.
everyone hear me now?
Yes.
We can hear you too good now.
Okay, so I'm going to move this over to shared screen. And can you see that?
Yep.
Okay, so I'm at a little bit of a disadvantage because when I put it on speaker, I'm getting feedback. So
You hear the feedback as well.
So I'm going to take that off, and I'm not going to be able to hear anybody say anything unless I put my cell phone in my ear. So I'm just going to present today, and then I'll have to coordinate when I take it off and mute, put on speaker so I can hear you talk. So anyway, so the month of we continue to stay on a good financial pace through February, 8 months into the fiscal year. This is somewhat characterized by the projected bar here being the highest of the last 3-4 years, 3.5 million or so. Keep in mind, at least half of that projected number by year end, it will be a result of adjustments from prior year. Having said that, we did have an important financial event that transpired this fiscal year in November when we succeeded and submitted the COVID stimulus approval, the 4.5 million that we were feared may have had to pay back, and we succeeded in providing the documentation. The next item that I wanted to discuss is the ER visits. And you can see we're considerably up in the current year compared to last year. And that, even though we're a little bit below budget, but this is like an 18% jump from last year. So ER has been a lot busier. And so overall, we are showing increased revenues and we're managing our expenses quite well. So I'm going to go to the next page on assets, mostly to make reference to this new item that we're showing in line number 2, cash all sources. And that's designed to show you a number that we're going to use going forward when we analyze our financial position as it relates to our ability to complete the seismic project. And this number of 26,504,000 represents all money that could potentially be used on construction like the seismic project. And then the nice news for this current month is that number increased by 1.8 million compared to prior month, mostly due to a 3 million coming in on IGTs. Just going to jump right into the monthly P&L and make reference to the fact that our line 6 total gross revenues came in within 1% of budget, 0.62. The big negative here was, well, outpatient was close to break even. So we have a combination of busy ER and also the higher amount that we saw on outpatient, especially as related to CT scanner, was up several $100,000. So we got a lot of CT scans used in the month of February. Also a favorable number, as you go down to this line 28, you can see we did manage our expenses 29,000 below budget on total operating expenses. And the bottom line of 182,000. So that's 135,000 better than budget. And then bottom line 460, which was 400,000 ahead of budget for the month of February. Moving on to year to date, we see a improvement as it relates to gross charges, 2.78%. The next category, net patient revenue, and again, this is where the prior year comes into play, where we were able to show some of that money coming in that hadn't been reported from the prior year. So that's part of that favorable variance shows up on line 11. Actually, the reduction on line 10, which is deductions from revenue, was declined from it's based on how we adjust when we realize that we don't have to pay back the COVID money. But again, on the expense side, I'll make this a little bit bigger. We see line 28 coming in for the year, 560,000 below budget on expenses. And then what we're doing on line 30, starting this month for the last 5 months of the fiscal year, we're going to be recording a 200,000, moving 200,000 a month over from the payable liability as we continue to show an additional amount of COVID money not having to be paid back. So about 200,000 each month will show up on this line 30 as COVID grants. So we have a bottom line of 2.2 million. And that's about 1.8 million I have budget for the year. And I'm gonna now try to put this back and then take myself off of, put myself back on mute.
We can't hear you. You muted yourself. Gotta put his phone back up.
So now I'm.
Put the other one on
Okay, so
mute.
I'm gonna. So I can hear you, but it's got an echo.
Put your other one on mute then. Or your screen. If you're talking through the phone, there you go. Try that.
That's weird.
He's not gonna be able to talk to us.
Can you hear me now?
Yeah, we can hear you.
Hello?
Go ahead. We hear you.
Can't hear us now.
Well, hopefully there's no questions.
Go
Ben's
back.
gonna be wanting to borrow his phone.
Looks like I need to get him a new one.
Dave, can you hear me at all? Can you do sign language?
And he's gone.
Okay.
I don't blame him.
You can try to dial in on his phone or something.
So Tim, do we know why, I don't know if you've spoken with Dave offline about this. Do we know why the clinic revenue is down 18%?
Well, Greg's right here. If we can ask him. I think a big part of it is obviously we lost Dr.
Because of COVID.
Lopez, COVID. Go ahead.
Because the COVID vaccines were included in our volumes for last year. All of the COVID shots that we did, that's the main reason. And even possibly some of it was from Dr. Lopez, but most of it's just from the lack of volume for COVID vaccines.
That makes sense. Thank you, Greg.
Can I ask a question?
Yeah.
I'll make a statement. We're still the most awesome clinic in the valley and probably throughout Bakersfield. So I never hear any complaints. And Dr. Mungar, the new doctor, everybody seems to be loving her as much as they did Dr. Lopez. So things have to be should be going right because we're doing good.
All right. Any other questions? Dave, can you hear us?
Can you hear us or can you talk, Dave?
I don't think it can hear us.
It's not, I just had a question. It's not important. I'll talk about it next time.
All right. Well, let's move on then to item F, the old business. And these are the items that, no, old business, there is none. So we'll just move on to new business, which is G, the employee rewards program. Tim, can you talk about that?
Yeah, Carrie is here also to kind of discuss this. We chatted about this in some of the committee meetings. What we're trying to do is put together a kind of a recognition program for the employees. That one that's done not only by their managers, but also employee to employee. And it's a relatively low cost program. We were looking for roughly $2,500 to get this started, which will allow us to kind of give each employee like a $5 start card from which they can go ahead and make referrals, recommendations on other folks. You reward other people and congratulate them for doing a good job, for helping out, for a whole host of things. And so the points that are given to each employee are to be used to reward other employees. And so they get, for example, 50 points to spend a month. And in there, they can donate all 50 to one person. They can donate 10 here, 10 there, 20 there, and so forth to recognize multiple people throughout the month. The employee is allowed to accumulate those points. Then at a certain point, they can trade those in for gift cards And there's like 160, 170 different cards they can apply for. And so they literally can get what they want, which is the great part about that. And like I said, it's just kind of nice, hearing something nice from somebody else, and so it was something that we wanted to try. And like I said, just to do something to try and get some goodwill going forward with our employees and recognizing their efforts and so forth. Carrie, do you want to add anything or?
I mean, that pretty much sums it up. There's no real, there's a small cost to us for this, just so that it's easy for them to sign into the program, which is $100 a month, but all the other costs that are going towards this are just trade-offs for whatever gift cards are there. So there's no additional anything that the hospital's paying. So it's a relatively cost-effective program, as Tim said. And I don't know if you mentioned, but one thing we're wanting to do too, to get this thing off the ground, would be to throw $2,500 at it initially, so that everybody in the district has a $10 gift card kind of in this program sitting there waiting for them, just to encourage them to begin to use this. Like, who's not going to go in there and grab $10, So that'll get them in there. And then, like Tim said, it's a great program to provide peer-to-peer recognition. Anybody can do it. Hey, good job for this. Here's 5 points, whatever. So I think he pretty much covered it.
Yeah, it's not like we're committed to a certain period of time. We can opt out at any time if we don't think it's working. Again, our thought was to maybe start at the $55 level, which is 50 points a month per employee. That would be a total, again, assuming that only about 70 to 75% of the staff actually do the points, would cost us about $12,450 a year. Maximum cost of about $16,000 if everybody did it. So it's relatively low cost. We can always up that later on if there's certain things that are going on. We begin seeing very positive changes occurring. We can increase that and so forth. Like I said, I included a line on here at 10 points, 100 points per month per employee, which is would be a total of about 23,700 based upon their usual experience, which is, like I said, 70 to 75% of the people that use them. So again, it's just, like I said, it's something that, like I said, that just we want to get some goodwill going with the employees and kind of get them in that habit of just saying something nice about somebody. And that goes a long way. It carries through when you begin noticing it from person to person. And so forth. So we wanted to get board permission to go ahead and try this for a while, and we can report back and see how it's going, and how many people are actually utilizing it. We can keep track of what's being said and so forth. So and just report back on our progress here in a couple of months here. So
I make a motion that we approve that.
Okay, we have a motion. Is there a second? Fred, you're on mute.
Should we try it again? I say we gladly second it. We need to do anything for morale to keep it up.
Are you gonna have discussion?
Uh-huh.
That Tim or whoever is listening.
Everybody.
We it's geared toward the employees. If we had a program where the employees made a suggestion on how to do something better and save money,
Yep.
if we took half of that money the following year, assuming it worked, then we would know if it worked, and put that in the program and make it available.
Yep.
You could tweak it however, but it would encourage not only people to talk to each other, but maybe look around on being more efficient. Does that make sense?
Absolutely makes sense. Yeah, no, I think it's a great idea. I've been a big fan of those kind of programs for a long time, and they're sometimes a little difficult because you get one employee will come up with a savings that saves $100,000, and so the question is, do you give him 50% of that, or do you?
No, not give it to the employee. I'm talking about giving it to the program.
Oh yeah, well, either way, yeah, I mean, that is better. Yeah, you keep reinvesting it back into the hospital.
Right.
I think that's the best way to do that.
Right,
So,
that's
yeah.
after it's successful.
You bet. You bet.
IT call 256. IT call 256.
By the way, I'm completely back. I figured out I went deep into my setup and my default speaker was on the wrong one. So I figured out the. So anyway, I'm working if we need to have a dialogue later.
Thanks, Dave. So who holds the gift cards?
Do you
Are the
think
gift
I have a
cards?
question?
I can do it. I can see it in you.
I'm just, well, I don't think $31,000 is a small investment. I mean, that's a pretty good chunk.
That's
I
if
mean,
everybody did it, yeah.
That's if everybody did it. Well, we would
And
hope,
we get $10.
Yeah,
right? So,
we weren't proposing that. We were going for the one below that.
well, yeah, I would, yeah, but, and so you want to try this for what, 2 months, 3 months,
I think it's gonna take probably
6 months?
6 months.
Yeah, I would say that that's
at
more
least 6,
appropriate,
yeah.
just so that word gets out, people understand the program. Something like this, you're gonna have some pretty quick initial adopters, and then it's going to have to be word of mouth in a way for people to be like, hey, this thing's cool, explain it to their peers.
The other side of it too, Catherine, is it's probably gonna take a while to accumulate enough points where you can actually get something decent, where you get enough money on the card. Like I said, with the $2,500, we were preloading them with $10 right off the bat.
Okay, so if we went with the 31,000,
Yeah,
just looking at that, and we do it for 6 months,
yeah. This is
we could
annual.
buy everybody, right, but I'm just, you could probably buy everybody a $400 big screen TV and say, here you go. I'm just saying,
In my mind, that's a one-time thing that for a temporary period may boost morale. What we're going for is some longevity here, is that every time something great happens or somebody does something well, you have that extra recognition that's available to give to somebody that says, hey, good job. And so maybe, that's certainly an idea, you could do something big, but it's just this ongoing,
no,
good job
I
type
get
thing.
it. I'm
Just
I'm
get
just
another.
for it. I just want to, I'm not totally against it. I just want to understand. It's, sometimes we sabotage ourselves with morale. I hate to say that, but, and hopefully they would take it and utilize it and not be, given to like the same person all the time. You know what I mean?
Well, the nice part is we can kind of track that. I think
Okay.
that's the advantage we have here. If someone doesn't appear that they're using this appropriately, we can step in and, say something or, I think that's the nice part is we've got the ability to see what's happening.
Okay.
And so forth. And like I said, I've had other programs that I've done at other hospitals. I know when I was with Dignity, when they were CHW, they administrators had a checking account that they were given that if they saw somebody do something, they could literally right there on the spot, write them a check and hand it to them and say, thanks for a good job. And don't want to go there again. But, there's all kinds of things to kind of reward that, hey, keep it going. Keep doing this. This is working. It's making a difference in the organization. And let's do that. So, like I said, this
And
is
so when
something I
they,
thought we might be worth trying.
when they have their points and they go to utilize them, there's like a website they can go on and choose. And so this covers them logging in and all that also.
Correct. So that's that extra $100 a month that I was talking about.
Okay.
So it's going to use their same credentials as they use to log on to the computer now. It'll tie into that. So
Okay.
they don't have anything new to learn or remember.
Where will will it show us a separate website they have to go through? It will be.
Yeah,
on
we have an intranet site that has like all of our stuff on there, and we'll throw this.
Just
in
put it
as
on
link.
there.
Yep.
Okay.
Kind of front and center, at least in the beginning, few months, so that everybody's can't help but not see it,
And so does the board have access to, if we see somebody doing something that we can also participate?
Thinking through it.
I'm just.
Yeah, you guys,
We could.
you would be able to do it. It's a public website. You guys technically have credentials to get into our system here. And so you would be able to use your own.
So we'd have to give them points each month.
Oh, I don't need it. Well, oh yeah, to start, that's what you have to do.
Well, no.
No, every month, the way it works is every month you're, like I said, if you went at the $100 or 100-point level, every month your pot would be renewed with 100 points. So if I only use 70, then next month I only add 30 to get you back to that 100.
Okay.
And you don't roll them over. If you don't use them, they go.
You lose them.
at the end of the
Okay.
month. Yeah. So the point is you want the program to encourage them to give them out. So
People who are getting them can
people who are getting them
Can
can
bank
bank
them.
them. Yes. Yeah, exactly.
Okay,
Carrie, would there be any way to involve the patients? I know that you gotta log in and do stuff like that, but as a side, because if you ask the patient, I'm doing good, they think you want to do good.
The answer is no right now with this program.
Okay.
That would require quite a bit of thinking to come up with something like that. But
There are ways, there's policies against that too. There are ways that could be done. In other words, if patients recognize an employee's performance, that a manager somewhere, we could
Get
say, fine,
notified.
we're gonna give you points because we got a great recommendation on you. I want to be careful because I want them going back and seeking that approval. Right.
Well, if you're seeking from the patient that you're doing good, the patient knows you're wanting to do good. So it could be a positive both ways. So
Yeah, I gotta think through that one.
just
I'd say both ways.
Do we run into any risk of falling into kickbacks or anything like that with this program?
That's not really a kickback for service or anything like that. So I'm like I said, I kind of want to keep this at the employee level. I think when we start getting into the patient stuff, it gets a little more kind of skewed and could set us up for something. So I think we're just going to keep it for employees right now.
You had physicians and contractors involved, you'd probably have a kickback issue. Amongst employees, probably not. You have limits on employee bonuses and gifts, but I think that this is probably within those limits as it's currently constructed.
Thanks, Scott. So the gift cards themselves, is this administered by the organization that is tracking these points, and you can like select from a catalog what you want? Is that how it works?
Exactly that. So there's a huge list of, I think it's 127 different companies that participate in this, all big brands, Amazon, Target, Apple, all these things that would be, desired. And then the employee would just go in once they have however much in their pot that they could spend, click what gift card they want, and they get a digital gift cards.
Does it get mailed, or is it just some kind of online credit?
It would be like a digital gift card. So they get an email with all that redemption information in it.
Okay.
and one more question, well, at the moment, but so if they go in and they want something that's at a higher price than points they have, do they have that option just to use the points and add to whatever also?
Well, it would be they're just going to Amazon, right? So if you have a $50 Amazon gift card, you use $50, spend the other 50 on your own.
All right, perfect.
Your redemption points and you reduce it by whatever that matters.
Well, it sounds like a great idea. I hope it's successful. You said you want to report back in 6 months. How about if we hear from you after the first quarter, maybe our September meeting?
We'll do that. We have no problem with that. Like I said, I think I'd want to run it for at least 6 months just to give people an opportunity to earn enough to really.
And it's going to take me once we get approval and all that. I mean, we got 3-4 weeks before we're ready to flip the switch.
Started, yeah.
Okay. So we've got a motion and a second. Is there any more discussion?
It would be helpful if you guys decide what level you would want to support this to. So. I mean, my recommendation was to go to the 50-point level. I mean, if you want to go above that, I'm sure the employees would be happy with that. But.
So you're recommending the 50 equals 5 thing?
Yeah.
Do I need to amend my motion?
Yes.
Okay, I amend it to that.
Thanks. Fred?
And we're okay with
Second
that.
that as well, Ross. Puts us at roughly, we'll call it 18.7 on an annual basis based on that number.
Okay.
So
Okay, then.
I've got that plugged into the budget for next year too, so we're in good shape.
Great.
And keep in mind that the participation is not going to be 100%. So I know you just said about $18,000 and change.
That's a max.
I understand that, but I took that as a max number.
Not 100% of employees are going to participate with this.
Right.
Yeah.
I understand.
Okay. Gene, your vote.
Yes.
Fred?
Yes.
John?
Yes.
Catherine?
Yes.
And me too. I'm a yes. So let's give this a shot. It sounds like a wonderful idea. I hope it's successful. Sounds good.
Thank you. Thank you, Terry.
Okay, then we are to new business item 2, the Lao indemnity agreement. Tim.
As we shared with you before, again, with the plan of correction, as we are appointing a new pharmacist in charge, one of the concerns was raised in the event that something happened that somehow impacted her licensure, through that pharmacy issues, that she just wanted some protection built in. So what she had requested was a 1-year severance agreement with benefits. This would only run for a 1-year period of time, which would basically be, we would know before then if there was an issue. Anything beyond that or anything that was her responsibility in her normal course of doing her job would not be covered under this. So it would be only related to anything that was in the plan of correction that we've already been served with and we've already responded to. And so that's the request here. And so had Scott draft up this agreement. I've had her look at it. She is fine with this. Just need to get board approval to move forward with it.
Can I make a motion? We approve it as presented.
Thank you, Gene. Do we have a second?
I'll definitely second it, Ross. We went through this already. It's written well.
Thanks, Fred. Any discussions, questions by any board members?
Yeah, just a quick question. So after this contract is over after a year, you just negotiate a new contract that eliminates the severance part?
No, there's no contract. She's an employee.
Oh, she is an employee.
She's
not
an
an independent
employee.
contractor.
Correct. Exactly.
Okay.
And I have a question. So did this start on the day that she was hired? Is that what we're going back to?
No,
Or is it like after her
started-
90-day probationary
No, it
period?
started as of her assuming those responsibilities as the
Okay.
pharmacist in charge.
Okay.
Any other questions? Does any member of the public wish to be heard on this item? Okay, then seeing none. Catherine, your vote?
Yes.
John?
Yes.
Fred?
Yes.
Gene?
Yes.
And I'm a yes.
Thank you.
Brings us to item 3 under new business, the antibiotic stewardship support letter. Tim?
One of the things as part of our antibiotic stewardship program that they, seek, as Mark brought up before, there were 7 components to the antibiotic stewardship program. One of which is a strong support from the board of directors and from leadership to the antibiotic stewardship effort. And so this is the letter we created basically to confirm that the board as well as hospital supports this effort on an ongoing basis, is willing to provide the resources to make sure this happens. Again, this is a big part of the plan of correction issue that we did as part of our corrective actions. Just to say, listen, folks, we're all committed to make this happen and to make sure that we stay on this and so forth. And that's really what this letter is saying. So we're just asking for board permission to execute this agreement by Ross and myself. And we will forward this on to the employees as well as the members of the Antibiotic Stewardship Committee and the CDPH and if they show up.
Scott, is that letter okay?
Yeah, I'm looking at it.
Seems like a lot of liabilities wrapped around it.
What? No, there's no liability. Where's the liability?
Oh, okay.
Yeah, no, it's just basically a statement of saying, hey, we support the antibiotic stewardship effort and program. That's all we're saying here.
Okay.
We're not taking on any liability with that.
I'm fine with the letter.
Okay, good. Now, whenever I make a motion, it's only to sort of get things going. I'm not trying to stop anything or not trying. I'll make a motion. We accept it as presented.
Thank you,
So
Gene.
for time's sake.
Okay. Do we have a second?
I'll second.
John? Thank you. Any board questions, discussions? Any member of the public wishing to be heard? Okay, then we'll move to a vote. We have a motion by Gene, a second by John. Gene, your vote.
Yes.
Fred,
Yes.
John,
Yes.
Catherine,
Yes.
and I'm yes. Thank you.
Thank you.
Okay, now we'll move to the items that were pulled from the consent agenda. The first item is the Board of Directors minutes from March 7th. You know, I was reading through these this weekend and just saw some errors or omissions, and I just wanted to correct them for the record. On item 6, the Chief Financial Officer report, in the last sentence of that first paragraph, it says the district saw a loss of 43,506, leaving a fiscal year to date of 1,789,000. And I just wanted to make sure it said profit, and so it wasn't assumed that it was a loss of 1.7 million. It doesn't state in that sentence, so it just seemed like there was a word omission there.
Yeah, it's a profit, 1,000,007.
Yeah. So that was the only correction I had on those minutes.
So
We'll entertain a motion to approve these minutes.
All motions, Ross.
I'll
Thanks,
second.
Fred. Thanks, John. Any discussion or questions? Anyone else wishing to be heard? Okay, John, your vote.
Yes.
Catherine,
Yes.
Fred,
Yes.
Jean,
Yes.
and I'm a yes. Thank you for that. Okay, then item 5. On the consent agenda was the board and planning meeting minutes of March 29th. And on item G, which is the status of the water line from Kissick Tank for non-potable water. There was nowhere in the record here why we're asking for the water, and it seems to get lost in our discussion. And I just think it was important that we put in the reasons why we're asking for this water. We did discuss it in the meeting. It just didn't get reflected in the minutes that. So my proposal is that we change the last sentence of that paragraph to read, Mr. Easterday will also check with Mr. Kissick to confirm where the water line feeds, comma, and determine if that non-potable water supply can be used for the hospital's cooling towers and irrigation of our grounds.
I'll make a motion, we make that change.
Thank you, Gene. Do we have a second?
I'll second, Ross.
Thanks, Fred.
as you recall, just Ross, again, this was offered to us. It wasn't something we asked for. It was, he just threw it out one day of just saying, hey, I've got that water across the street. He said, I would love to be able to, you guys could use it to water your front lawn. He said, just to keep that beautiful looking and stuff like that without it costing us and stuff like that. And I think that's where the questions came up. And then until recently that we found out there may be an opportunity for us, because the issue was going to be the cost of tunneling underneath the street under that's a wide street out there at that point in time. And so, and then apparently we found out that his water systems also fill the
Fire
hydrants, thank you. And so there may be a way for us to tap off of that on this side of the street. So, which would be great if we can do that. But you're right, there was a discussion with regards to whether or not that could be utilized in our air systems. So they're gonna check on that.
Okay. So we have a motion and a second. Any other discussion? Any member of the public wishing to be heard? Okay, Fred, your vote?
Yes.
Catherine?
Yes.
Jean?
Yes.
John?
Yes.
And I'm a yes. Okay, and then the next item
It was Finance Committee.
There it is, Finance Committee from March 30th, the minutes of the Finance Committee meeting. Under paragraph B, the changes to the agenda, it's just an incomplete sentence. There's a, there will be discussed immediately following public comment to allow Mrs. Villa to, and then whatever the thought was didn't get typed out, so.
I think it was to allow her to go first in order to explain her capital request.
Okay. So just wanted to see that that got corrected, so it's,
Okay.
we've got it correct for the record. So entertain a motion to approve that.
Yeah, that was the ultrasound probe, right?
Gene,
Second.
Did
All
we
right,
have-
first or second, whichever you put me.
you're making the motion, bud.
Oh, okay, make a motion to accept it as you
All right.
presented.
All right, I'll second.
Thanks, John. Any discussion? Members of the public wishing to be heard?
Yeah, there's two of them.
Was there? I didn't. Okay, seeing none, then we'll vote. Fred, your vote?
Yes.
Gene?
Yes.
John?
Yes.
Catherine?
Yes,
And I'm a yes. Okay, then that takes us to the beta item G, liability. This was under contract review, and the recommendation is to continue with the agreements that we already have. And Gene, you wanted to discuss the beta liability?
Yes, at the meeting, I didn't want to, I wanted to pull them, in which we did, until we got the, what we're approving, the new premium, we won't know. It's July 1st is the renewal date, so it's way in advance. And what I asked for was the previous, just to look at a trend line, the previous 3 years and the current one coming up. So that would be 18 to 19, 19 to 20, 20 to 21. Real simple. And the new renewal. 3 years. That'll give us a good trend line.
And I did send that out, so I don't know if anybody else. saw it.
And Gene, I thought that was a reasonable request. I think it can be best handled at the beginning of June when we have the new numbers from beta, so that you truly are either approving or disapproving.
Right. And I'm sure it's all going to be fine and wonderful. Just looking for the trend, and they're a good company. Everything is great. It's just, we want to see if we need to make any changes in the way we act.
Yeah, I can tell you it dropped from 2021 to 2022. I think it went from like 130,000 to 126 or something, like dropped a couple $1,000 or 4,000 maybe. And then, and obviously now we're bidding on fiscal year 2023. So
And
the next year.
my concern is that you'd be approving our relationship with beta, and then the potential is there for us to come back in a month or two and say that the new rates are really way over with what we
too late
are recommending, and you've already approved it. So
okay,
Well, the issue we're going to get into, and this is what we got to be careful about, is that in the meantime, we're not seeking any other bids. And so if we come back and say at the last second that these are too high, you know, we risk, you know what I'm saying, Dave? We risk, we've got to, you know.
Tim, they have to give you those rates 60 days prior.
Yep.
So
Hold on.
don't say we won't have time. You'll have them in your hand.
No, I'm not talking about those. I'm talking about other bids. If we had to go outside and get other bids. is what I'm
We
saying.
have 2 months because they have to tell you what it's going to be 2 months in advance.
Yeah.
All right, hold on a sec. Beta is not an insurance company. Beta is a joint powers agency. The district is a member of that agency. It's another government agency that we are a part of. They're not subject to regulation by the Department of Insurance.
Okay, so the liability insurance is not regulated by the Department of Insurance.
No, it's like a risk management pool. So it is a government agency that we are a member of, and we pay a certain amount into that pool every year. And then based on a number of factors, whatever that amount is determined on an annual basis.
It's a government agency?
It is. Department of Insurance has no authority over.
Okay,
Beta.
but what government is backing it up? State of California?
It's an association of California healthcare districts. So Beta is comprised of a whole bunch of healthcare districts that pool funds to share risk.
Okay, what government's backing it up? You said it's backed up by the government.
The members.
It's a regulation allows it.
So Kern Valley, Tehachapi is part of it, Southern Indio is part of it, Truckee is part of it, Scripps is part of it. All of the healthcare districts who are members are the ones that fund and support the government. To my knowledge, the state of California does not guarantee.
Okay, so it's an association, basically,
Correct, right.
and that's it.
And most
So
of the
we don't have any
45 districts-
guarantees.
Yeah,
most of the
we're one of the
45
founding members.
Okay,
You
and
are
I'm
a
not-
member.
I'm not saying it's good or bad. So far, it looks like it's been good. The history of it and what I've seen, it looks good.
Yeah, and their service has been spectacular.
We still need to see what they're trending and how they are, not
Yeah.
necessarily to find, because I don't think we'd find much better, but.
Right.
I always like to have the negotiating leverage of not having an approval until we get the new rates, so.
Yeah.
Okay, well, wouldn't they generally, Scott, try to go by what the rules and regulations are? They're using the same, no?
No, you guys have bylaws with Beta. Beta has set its own rules for how it operates. It is not an insurance company. And so it operates under the bylaws and contractual relationships
Risk management,
as
okay,
with member agencies.
okay. Yeah, well, now David, you were gonna check with them to see when they might have the next rate. Well, the property and casualty shouldn't be any different because there's been no change in the industry to speak of.
Yeah, and I've already had some in-depth conversations with Alliant, who is the property and casualty carrier. And we're still going back and forth on the coverage because of the premium is a product of how much coverage they're giving us. And we're contending that they're giving us more coverage than we need.
Yeah. I can tell you from experience, you never have enough. When you have a loss, it's a problem.
With Alliant, there's a nice underlying $150 million limit that you fall under. That's why they want to increase your coverage so they can get more premium. It's a little bit
Yeah,
complicated.
you're doing a good job, man. That's cool. that you're-
In Beta, I've had really good luck with Beta, and I really am glad to see the board is, favorable toward them because they're a good company.
Wow, I hate to tell you again, you're doing a good job, but
Thank
you're
you.
probably tired of hearing that.
Well, I was hoping I'd mess up so bad on my presentation today that we'd stop, but now that I got my speaker back, I can hear you.
Okay, now we need a motion. What I said, do we need the changes I don't know if we made changes. We're
What
just
we
saying-
could do, what we can do is just table these until June.
I'd like to table until June if it's possible.
Okay, do we need a motion for that?
No,
Okay,
we'll just ask Dave to bring these back in June.
okay, then if we're under discussion now that we can communicate with Dave, can I ask him a question?
Go ahead, Gene.
It's up to the chair. I'm really messed up the meeting today. So.
Go ahead.
No, you did awesome. The question was, gifts sometimes from the government, I have seen them in this COVID situation, change their mind so many times right from the president down, including both of our presidents. There's been so many changes. And you're talking about, we don't have to pay it. Is there a timeline where we don't have to guess where we're certain that we don't have to pay it back? Is it 21 years or is it 5 years or?
And I've asked that same question to the District Hospital Leadership Forum because they represent district hospitals on reimbursement issues like this. And they've always sounded like an attorney that they speak from both sides of their mouth. it's really hard to get a straight answer.
I wasn't listening to you.
It's hard to get a straight answer. And it's one of my biggest frustrations because we have this uncertainty.
Can we at least be reasonably conservative on the questionable areas? Because hard times are coming. It seems like the reasonable thing would be for the county to want to claw some of it back when they want money. But at any rate,
All good points. Whether we keep it on our books or not is probably not, but there's always that potential. For example, we had to pay back $600,000 this year on a SNF reimbursement from 2012 that was just determined this year. So, you talk about clawbacks.
Crazy.
So that's a good example. And, can I guarantee that something like that's not going to happen again? We don't know.
Yeah, but we should keep it in the back of our mind.
Oh, yeah.
Because they could bankrupt us if they wanted 5 million back all at once.
You would think that there'd be statutes of limitation and those kind of things. And I'm just shocked that some of these things are continuing to come up from many, many years back.
Well, at least make it as long as I'm around and you're around, that if it has to be paid later, it's not a big deal.
But you're right. The temptation is going to be if they can figure out a way to get the money. I'm also a little confused because the state of California is supposedly has this big surplus this year. And I don't know why they're being the way they are toward healthcare.
Because they got it sitting, waiting, trying to figure out where to put it later. But at any rate, it's a different story.
Okay, so let's move to item H, the director's comments. Gene, any additional comments?
Nope. Everything seems to be going good.
All right. Catherine?
No comments.
All right, thank you. John?
Yeah, just a couple quick things. I wanted to say I'm happy to hear Vince coming back to our area. I know Vince has been familiar with this area for a long time. He's worked in different government positions over the years, so good to have him back in the district representing us. Kind of on that same note, I actually talked with Carrie's dad, Gary, about veterans services, because I know that's in our strategic plan. So he kind of put a bug in my ear, so I'm kind of trying to figure out some ideas to maybe get some kind of see if there's some kind of partnership we could possibly do with the VA hospital, maybe once a month or something, just to kind of get the process going. Sure. And we can talk about it in the strategic plan if it materializes. And so I'll keep you guys posted on that. And then finally, just wanted to thank everybody who reached out when my stepfather passed away a few days ago. It's been a rough process for the family, of course, but thank you for reaching out and seeing if my mom and everybody needed something. So I appreciate it. That's all,
John. Fred, Mr. Fishing Derby.
Thank you. A little tired, but I'm good. The only comment I have is just thank you to everybody for being here. And Dave, as always, thank you for everything you do. The reports are very detailed. We appreciate it a great deal. Mr. Elliott, it's all yours.
I wanted to share, I was on social media. I was on Facebook last week before last, I don't know when it was, sometime recently. And somebody had posed a question to the virtual world of, how are the doctors in the hospital up in Kern Valley? I'm considering moving there and kind of want to get your opinions. And there was comment after comment of how wonderful our hospital is. You saved my life. You saved my life. You saved my wife's life. It was really heartening to see the amount of support we get from this community because of the services that have been provided to them. And I thought that was so gratifying to see all that coming back in spades to the district. So I wanted to share that.
Always been the case.
Yeah. you know, there were a couple naysayers. Oh, I had a toe injury and had to wait a long time in the ER. Well, you know.
Yeah.
But, you know, by and large, the comments were really favorable. And I just thought that is so great. So thank you. Thank you for providing great services to our community. I'm an advocate of this organization, and I'll do everything in my power to make sure we remain viable. So thank you all.
Ross, can I make a comment on that?
Sure, Gene.
That was only since you've been chair of the board. I looked at all those dates. And
I don't think so, buddy. Okay, we're going to convene a closed session. So we're not adjourned, but we do need to have people that are not on the board step away so we can have a closed session. All right. Okay, the board is reconvening from our closed session. We're now back in open session, and Mr. Nave, can you give a closed session report?
Yes, in closed session, the board conducted a performance evaluation of the CEO. No action was taken and no other items were discussed.
Thank you. With that, folks, then we are adjourned. We will see you at the next committee meetings and the next board meeting.
thanks, everybody.
Yeah, thank you.
Thanks all.
Thank you.
So Heidi, yes.